This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2015, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, certified asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Comparison of Proportional Assist Ventilation Plus, T-tube ventilation, and Pressure Support Ventilation as Spontaneous Breathing Trials for Extubation, a randomized study. Upon completion of this AARC webcast, participants will be able to identify the research question of the study, identify the study design, discuss the main results of the study, and discuss the implication of the study on patient care. I am pleased to welcome Tom Piraino. Tom is a registered respiratory therapist from Hamilton, Ontario, where he is the best practice clinical educator for respiratory services at St. Joseph's Healthcare. He is also an assistant clinical professor for the Department of Anesthesia, Division of Critical Care at McMaster University. Tom has published several peer-reviewed publications and book chapters on mechanical ventilation. I disclose that I am an employee of the American Association for Respiratory Care, and Tom discloses that he is a speaker for Draeger Medical. Tom, welcome to the program.
Thank you, Shauna. All right, so let's get started so that we can leave enough time for questions. So Shauna's already mentioned the title of the article, and it was available this month in Respiratory Care.
Tom, I think we just lost your sound. I think your microphone shut off.
There we go. Can you hear me now?
We can, thanks.
Okay. Sorry about that. I think I clicked the wrong button. Here we go. So the article starts off with the background that weaning refers to the gradual and progressive transition from mechanical ventilation to spontaneous breathing for patients that have been ventilated more than 24 hours. Failure to wean can prolong both mechanical ventilation and ICU hospital stay and increase complications related to mechanical ventilation. Now, before I continue, I just want to point out that sometimes the word weaning and liberation are used interchangeably, and really this article is looking at the liberation process, not so much the weaning process, and we'll get more into that once I discuss the editorial as well. The background, again, still continued even after a successful spontaneous breathing trial. 10 to 20% of patients may fail extubation. Spontaneous breathing trials, these protocols and screening conducted by physiotherapists yield good results, are effective and highly recommended. Of course, this also applies to respiratory therapists. But you have to keep in mind that where this study was published, and I'll discuss that in a moment, physiotherapists do the role of spontaneous breathing trial, whereas, of course, in North America, respiratory therapists would be doing that. Discontinuation of mechanical ventilation involves several steps, one of which is a spontaneous breathing trial. If a patient tolerates a spontaneous breathing trial, they are eligible for extubation. And a spontaneous breathing trial is simple and among the most effective for weaning. Again, I would probably change that to liberation. Most commonly used techniques are the T-tube and pressure support ventilation of up to 7 centimeters of water. Now, that information, they referenced this article here from Esteban from 1997, where they compared T-tube versus pressure support of 7 as a spontaneous breathing trial. And as you can see, I plugged in the numbers of the percent patients that failed extubation. It was 18.7% in the T-tube group and 18.5% in the pressure support group. So they had equivalent results of failure from extubation, so they required reintubation. But it didn't matter whether they had T-tube, which is complete removal from the ventilator and just providing oxygen through the endotracheal tube, or pressure support of up to 7 centimeters of water. Proportional assist ventilation, or PAV+, as it's referred to in this article, is a spontaneous mode of mechanical ventilation designed primarily to respond to changes in the patient's inspiratory demand. PAV+ can be used as a replacement to pressure support ventilation in spontaneous breathing patients, and studies are lacking in which PAV+ can be used in a spontaneous breathing trial. So the aim of this study is to analyze PAV+ as a method of performing a spontaneous breathing trial, assess the applicability, safety, and efficacy of PAV+, and the primary outcome was extubation success and failure. Secondary outcomes were mortality, duration of mechanical ventilation, ICU, and hospital length of stay. The authors claim no conflict of interest, and I've added this slide here just for some of the considerations. So PAV+, the mode that's used in this study, is a proprietary mode available on the PB840 and the PB980. Other proportional assist modes such as NAVA or proportional pressure support are available in other ventilators, but they were not tested in this study, and they obviously function very differently. So this can't be generalized to all proportional assist style modes. It's specifically PAV+ on the 840, and they do claim that very specifically in their article, that all of the patients randomized to that arm did require to be on the PB840. That they did not have the PB980, I'm guessing because it wasn't mentioned. The methods for the research were prospective, non-blinded, randomized controlled trial conducted over 1 year in an adult ICU. It was in Brazil, and that explains why the use of physiotherapists to do these spontaneous breathing trials exists. Of course, they had ethics approval and informed consent obtained from subjects or their legal guardians. They included subjects in the ICU who remained on mechanical ventilation for more than 24 hours. They excluded patients that had a tracheostomy, death without weaning, self-extubation, extubation by clinical decision. So in other words, they decided and performed by staff not meeting protocol requirements, and progressive neuromuscular disease, and spontaneous ventilation maintenance. Not mechanical ventilation. The primary extubation of the subject was considered for the analysis. In other words, if they got re-intubated, they didn't reanalyze after second extubation. After sample collection, now this is for the research data collection aficionados out there, assuming a medium effect size and of 0.25 and type 1 error of 0.05 with 3 groups, a power analysis was performed, and that's the software that they used, with a value of 0.81 for the 160 adult subjects that were randomized. Please don't ask me a question related to that kind of information. That's my weak point, but I thought I'd throw it in there anyways. The subjects were randomized after discontinuation of sedation using a simple draw for 3 distinct groups, PAV or PAV+, PSV, and T-tube. To start the protocol, the following criteria was met. They had to have an improvement or resolution of the cause that led to acute respiratory failure. They had to have adequate gas exchange defined as a PO2 greater than or equal to 60 millimeters of mercury with an FiO2 less than or equal to 0.45 and a PF ratio of at least 200 or greater, PEEP of 8 or less, Glasgow Coma Scale of 9, peripheral temperature 38 degrees Celsius, low doses of vasoactive drugs, and hemodynamic stability, so they required between 70 and 105 millimeters of mercury of the mean arterial pressure. The qualified subjects underwent predictive testing for extubation, so they used maximum inspiratory pressure. It had to be negative 25 centimeters of water or less, a rapid shallow breathing index of less than or equal to 105. They had to have an effective cough with a scoring greater than 3, and the scoring is explained. 0 if they had no cough, 1 if they had audible air movement through the endotracheal tube but no actual cough. 2 is a weak cough, and 3, the cough is clearly audible, and 4 is a heavy cough, and 5 is a multiple cough sequence. And they also had to have a positive cuff leak test. Now, the methods that they use to assess the effectiveness, so the maximum inspiratory pressure and the PF ratio, I just brought up this paper here, and they reference this as well. It's by Yang and Tobin. It's from 1991 in the New England Journal of Medicine. And what you'll see here, I'm just going to get a little pointer here, that the positive predictive value of the frequency over tidal volume, which is the RSBI, has the highest positive predictive value, and the highest negative predictive value is the maximum inspiratory pressure. So now, having said that, if you happen to work in an ICU that doesn't use maximal inspiratory pressure and you only use RSBI, you can see that the RSBI was the second highest negative predictive value. So the highest positive predictor and the second highest negative predictor was the frequency over tidal volume ratio. So this is why this has become sort of the, I don't want to, lack of a better word, gold standard for assessment for readiness for spontaneous breathing trial is the rapid shallow breathing index. Now, if unable to start the protocol, the subjects were maintained on mechanical ventilation and reassessed after 24 hours. These are the characteristics of the patients, sort of the baseline characteristics. So what you're looking for when you look at the baseline characteristics of patients is you want to make sure that they were sort of equally distributed. So this is basically a 3-way randomized trial here. You have 3 different methods that were used, and when you look down the side along the p-values, you can see that none of them are reaching 0.05. So they were all equally distributed. The protocol, prior to randomization, patients were ventilated with volume-controlled ventilation, 7 mL per kilo of predicted body weight, using flow sensitivity. After randomization, the PAV Plus group was ventilated exclusively with the PB840, set to PAV Plus with the percent support adjusted to maintain subjects in a comfortable range. And the range that has been quoted a couple of times in the literature that I've been reviewing is 0.3 to 0.7 joules, and which is considered the optimal working level for patients. The pressure support group was ventilated with a PB840 or an Inter 7 Plus ventilator in spontaneous mode, and pressure support was reduced to 7 centimeters of water. The T-tube group was disconnected from a mechanical ventilator and connected to a T-piece with supplemental oxygen adjusted for SATs of greater than 92%. The spontaneous breathing trial was conducted for 30 to 90 minutes. The trial was interrupted if intolerance was observed, each one lasting for at least 2 minutes or until resolution. So they looked at breathing frequency of 35 or more would be intolerance, SATs of less than 90, heart rate of 140 beats per minute, sustained increase or decrease in heart rate of more than 20%, so either one of those happening, systolic blood pressure of 180 or 90 millimeters of mercury, agitation, sweating, anxiety, or decreased level of consciousness. If intolerance was observed, the subject was maintained on mechanical ventilation and reassessed after 24 hours. The spontaneous breathing trial could be repeated using the same method in the following 2 days, so they had 2 more chances to try. Subjects who passed the trial were extubated and given supplemental oxygen therapy via a face mask. When indicated, subjects with COPD, non-invasive ventilation was initiated immediately after extubation. And extubation failure was defined as reintubation within 48 hours. And just a quick comment about the extubating the COPD patients to BiPAP. There's significant data suggesting that extubating patients who do pass a spontaneous breathing trial but have underlying hypercarbia, extubating them directly to BiPAP has improved outcomes. So it would be somewhat, if they weren't doing this, then someone may say that perhaps they should have been using that to help optimize the patients that did have underlying COPD. So it is good that they did that. I was actually impressed that they included that option for COPD patients. The statistical analysis, again, this is for all those research aficionados. You got data distribution of quantitative variables was assessed using the Shapiro-Wilk test. Homogeneity of variances among the group was assessed using the Levine test. I won't get too much into detail with this. All of this information is in the article, and maybe if I talk about it too much, I may get answered questions about it. So I'll just move on now. The frequency of qualitative variables were compared between the groups using the chi-squared test for K proportions. The frequencies of the need for non-invasive ventilation at 0, 6, 6 to 12, and 12 hours were evaluated, and the significance level was defined as 0.05 for all statistical tests. The logistic regression analysis was used to check for successful extubation characteristics for each method. And for application of this analysis, the legit model, stepwise forward method with binary response was used. So this is sort of an overall view of how the patients were sort of distributed throughout the study. So 486 patients were admitted to the ICU, 321 were excluded for the reasons listed there. 165 went on to basically be looked at for the spontaneous breathing trial for this protocol for the study. Now, off to the side it says failed SPT 5. Now, I looked over and over through the article to really understand what exactly this was, because when it says SPT 165 but then 5 failed, I mean, there were patients in those 3 groups that failed, so what I'm thinking this is referring to, it just wasn't explicitly stated, but I think what this was referring to is people that failed the predictive testing for extubation. So when they went to do the maximum inspiratory pressure or the rapid shallow breathing index, perhaps that's what that was implying, that 5 of them did not tolerate that. For various reasons, they weren't passing that at any time. And then of the other 160 patients were randomized to actually receive spontaneous breathing trials with the 3 different methods. But someone can correct me if I'm wrong with that. That was my understanding. The results in terms of successful first spontaneous breathing trial, time spent on the spontaneous breathing trial, 1, 2, or 3 spontaneous breathing trials accomplished. You see the only difference between the 3 groups was the time spent in the first spontaneous breathing trial of the T-tube patients. So again, they were doing these trials from 30 to 90 minutes, and the T2 patients, basically once they made it to 30 minutes or more, it looks like the average time was about 35 minutes there, so they were put either back on or extubated much quicker. it seems, in terms of how long they were put on there. But everything else considered, in terms of whether or not they passed the first one or needed a second or a third, those numbers were insignificantly different, so they were all similar between the three groups. Again, this is just another way of looking at the data. The subjects, so 160 were enrolled, 48 into the PAV+, 46 into the pressure support ventilation, and then 66 to T-tube. You can see the success and failures are basically very similar in terms of percent failures compared to the total amount of patients in those groups. And it breaks it down into what happened to the people that failed. So you can see in the PAV+, there were 6 that failed, 2 were eventually extubated successfully, 4 of them received a tracheostomy. In the PSV, 6 received tracheostomy, there was 1 successful extubation, and 1 patient died. And then in the T-tube, we had 2 tracheostomies, 6 successful extubations after initial failure of the spontaneous breathing trial, and 2 of those patients died. Again, in terms of those outcomes, there was no significant difference between the 3 groups, which was essentially, in terms of mortality, extubation failure, required tracheostomy, etc. You can see all lined up here. You have ICU stay at the top, hospital stay, time to reintubation, and those other factors, none of them reaching statistical significance, as you can tell by the p-values over here on the right side. Now, what they looked at was the prognostic factors related to the incidence of extubation. So what this data is basically describing are sort of the factors that predicted not only successful extubation, but also what would happen if you failed extubation in the example of ICU stay. So the rapid shallow breathing index and the PF ratio basically both significantly predicted the incidence of extubation, so the success of it. So the lower your RSBI was, the more likely you were to have a successful extubation. The higher your PF ratio was as well would also predict more successful extubation. The ICU stay, of course, if failed, if you failed extubation, your odds of requiring an ICU increased length of stay in the ICU did increase. One of the things they pointed out that in PAV+, if you were to fail extubation, your odds of having an increased ICU stay were basically a little bit higher than the other 3, but how to interpret that or explain that could be open for discussion. But basically, the main results of the studies were not different between in terms of failures, etc. So even the overall length of stay was not different between the 3 groups. So that shouldn't be interpreted too in-depthly. When divided into groups, traumatic brain injury was the leading cause of admission in the pressure support and T-tube groups. The main cause was trauma without injury, followed by medical non-neurological causes in the PAV+ group. This is just breaking down sort of the reason for ICU admission and how they ended up getting distributed. According to Neyman et al., when a specific population such as subjects with traumatic brain injury is considered, many subjects may pass weaning trials but fail extubation and progress to respiratory failure due to neurologic changes. They did not find that relationship, so there was no statistically significant relationship between extubation failure and the reason for admission in this study. And although they found no reports in the scientific literature on the use of PAV as a spontaneous breathing trial, many researchers have used it as a weaning method. And the reasons for failure and reintubation in our study were respiratory failure, followed by decreased level of consciousness and airway obstruction. And now, the reason why I bolded that statement at the top, that they found no reports in the scientific literature on the use of PAV as a spontaneous breathing trial, is in the editorial, the authors of the editorial actually state the opposite. So so when I bring that up again, you'll see that I compared the 2 statements of the editorial. So. The limitations for their study, the FiO2 during each method was not necessarily identical because in the T-tube group, the FiO2 was not measured. However, all subjects had to maintain SATs of 91% or greater, indicating that no subject developed hypoxemia during a spontaneous breathing trial. So what the actual FiO2 was really was not important so long as no one was failing because of hypoxemia, if they were able to increase O2 for that. So it was also a single center study with a small sample size. Now, sample size was significant for statistical analysis, so that's something to keep in mind. Although it was small, it was significant enough to collect the data and show significance. And also, single centers do help limit the heterogeneity between practice, so they're going to be treating these patients and managing them basically exactly the same because it's in one center. So there's benefit to having multi-center studies, but there's also the benefit of limiting heterogeneity when you have a single center study, so especially like this. In terms of using PAV versus pressure support, again, the data out there shows it as a successful or at least an option for weaning patients. So this is just an example of a study from intensive care medicine that was referenced in this paper, where they showed the probability of remaining on spontaneous breathing after switching to a spontaneous mode, and PAV plus over time, basically more patients were successful at staying on the support mode versus those that failed spontaneous breathing mode. So it has been used in the literature as a weaning mode. And the objective of the study was to assess the reliability of PAV as a method of spontaneous breathing trial, which was clearly demonstrated. Again, this is not a weaning study, and a lot of the terminology sort of confuses weaning with liberation. This was really saying spontaneous breathing trial. So the major focus of the editorial is that the results were exactly what they expected. So this is now referring to the editorial. One of the statements in the editorial was that this is quoted. The authors indicate that there have been 3 previous comparisons of PAV with pressure support during SBTs, where you can see below. So the research article referenced PAV and PSV comparisons with weaning, but not spontaneous breathing trial. And in fact, what they stated was they found no reports in the scientific literature on the use of PAV as an SBT. And even the references that were given for the above statement in the editorial, I looked them up, and again, they were the weaning studies. They were not used for a spontaneous breathing trial. So the authors of the original paper were correct. They did not find any reports in the scientific literature of PAV used as a spontaneous breathing trial method. The patient population they chose, again, this is from the editorial, the patient population they chose to study was one that generally can be rapidly discontinued from ventilatory support once weaning criteria is met. The study population was one in which no one would expect any intervention affecting the way a spontaneous breathing trial was conducted to have an effect on the process of ventilator discontinuation or on mortality. The most important factor that affected the lack of difference in the time to extubation was the use of volume control continuous mandatory ventilation. So they pointed out that in volume control, asynchrony is generally greater. There is an association between asynchrony and length of mechanical ventilation and length of ICU stay and mortality. Pressure support allows more control by the patient. Better yet, PAV follows the inspiratory effort of the patient. So as patient effort increases, the ventilator pressure work also increases. And again, they mentioned that NAVA also operates similarly using the diaphragmatic electromyographic signal as what they're monitoring, and then you set a proportion of work that is responding to the amount of signal sent to the patient's diaphragm. So essentially, they are both proportional in the way that if the patient is working or demanding more, the ventilator will then increase the pressure and the support to help them in proportional to the amount of work. So they operate on the same principles, but very different in terms of how it's basically delivered as a mode, or the underlying software behind it is what I'm trying to get at. So the editorial basically recommends this trial be repeated with a single approach to spontaneous breathing trial. In other words, if there's no difference in how these patients, whether or not these patients were successfully extubated, didn't matter what mode of spontaneous breathing trial they used. So perhaps having one single approach to spontaneous breathing trial, but with different modes of ventilation once controlled ventilation is unnecessary. So the minute someone is making spontaneous efforts and they're not in the acute phase where you're worried about spontaneous breathing, perhaps we should just, again, look at different modes. They expect that a mode of ventilation like PAV or NAVA that markedly reduces asynchrony would have a beneficial effect on time to extubation. And in conclusion, this is the conclusion from the paper, not the editorial. PAV Plus is a valid alternative for use as a spontaneous breathing trial. Compared with currently used methods, T-piece and pressure support is what they're referring to, no significant differences were found in the rate of extubation failure, duration of mechanical ventilation, or ICU and hospital stay. PAV Plus showed high predictive power related to extubation, confirming its ability, efficacy, and safety compared with the T-tube and pressure support, which was what they set out to sort of answer in terms of their research. And that's the last slide there. I hope I definitely gave enough time for questions and answers, because I have a feeling it's going to stimulate a lot of discussion, and I think I may even have some questions to stimulate the chat as well.
Thank you, Tom, very much. Actually, we have a couple of questions that I think are really good to help the audience who may not work with this particular machine or this particular mode kind of get a little deeper into the mindset of what the researchers were really looking for. So the question that sparks my my ultimate question is, theoretically, is NAVA the same as PAV+? Could you do a little bit of background for us on PAV+ and how that may or may not differ from NAVA, and how that then may have triggered the researchers to say, PAV+ may be a good idea to use for spontaneous breeding trials?
Right. So both PAV+ and NAVA are both, again, they're both proprietary modes for specific ventilators. So NAVA is available on the Servo-I ventilator and PAV+ on the 840. There's PPS available on the Drager, but PAV+ uses a very different method for how it's set up. So I'll discuss that one and then NAVA. So PAV+ basically works on the principle of the worker breathing equation. So what the mode will do is essentially basically measure the patient's respiratory system resistance and compliance, or elastance, every 4 to 10 breaths. It does a mini pause maneuver and calculates those two values, because they will be changing. If someone's breathing spontaneous, they can't just do a static maneuver. They have to sort of look at the trend over time in terms of what the resistance and compliance is doing. So it takes those two values, plugs them into the worker breathing equation, and then what you're doing is you're telling the ventilator what % of the worker breathing you want the ventilator to do. So if the patient resistance is high or their compliance is low, it's going to increase their worker breathing. So you would set the ventilator to do 80% of that calculated worker breathing. So then the ventilator decides how much pressure it has to give in order to overcome that worker breathing. If you set it to 50%, it's going to make sure that it's only doing 50% of the worker breathing based on that worker breathing calculation. And then on the ventilator is actually a bar graph that shows up. It's a horizontal graph that shows you where the patient's sitting in terms of basically the amount of energy, the joules that are being used. And there's guidelines not only from the company, but even in this article and other literature saying to try to maintain them between 0.3 and 0.7 joules, basically of energy expenditure. So you adjust the % of work you want the patient to be doing by telling it how much you want the ventilator to compensate. Now, NAVA is very different. It uses a catheter that's inserted in the esophagus and basically sits at the level of the diaphragm, and it measures basically the diaphragm, the signal the brain is sending to the diaphragm. So it doesn't look at worker breathing related to resistance or compliance. It looks at the amount of signal sent to the diaphragm, and then you determine how many centimeters of water you want to provide for how many millivolts of activity being sent to the diaphragm. So as the diaphragm is sent increased activity, so they want the patient's trying to breathe stronger or deeper or harder, then basically the machine will then proportionally deliver that support above that. So they're two very different techniques for how it's analyzing what it's going to deliver, but both of it responds the same way. If the patient is working harder, the machine will again give more support. If the patient calms down and relaxes, it will be proportional to that work of breathing and it will come down. So both of them essentially deliver the same proportional support, just very different techniques for how it's set up and how it's calculated, etc. And yes, Meg, I just saw a question that just popped up. Meg de Eunice was the inventor of PAV, so if you find his name on any paper, it's probably going to be discussing PAV.
So, Tom, over the years, sorry, my microphone just adjusted itself. I'm afraid I got too loud. So over the years, as we've debated various support modes and how much support we give the patient, and we debate this concept of I give support to overcome the resistance of the endotracheal tube, we also have to balance that with, am I giving the patient so much support that when I remove the endotracheal tube, I've kind of fooled myself into believing that the patient was ready for extubation when they were really not ready and I was doing too much work. So do we have any of that concern at this point, or is that really not that much of an issue?
I think the bottom line is the reason why we have these spontaneous breathing trials that we are aimed at delivering the least amount of support is to try to take away some of that fear of, am I over-supporting this person's endotracheal tube resistance or their airway resistance? Am I fooling myself? And this is why there's been different methods tested. So they've tested, TPs, pressure support. I do believe there's some papers on looking at CPAP. And the bottom line is that if you have minimal support, if you have no support, then one could argue that the worker breathing is higher breathing through a tube than it would be if you just took it out. This is why the use of TPs even exists, because they figured if they can handle breathing through a straw, then they can take it out. But I think that's become less and less of a concern in terms of the liberation process. but I think there's significant work to still be done in the weaning process or the maintenance phase of mechanical ventilation, where I think it's very easy for us to over-support the patients that are receiving support rather than over-supporting the patients that are being assessed for spontaneous breathing trial, assuming you're using one of now these three methods, basically showing that they're most likely not over-supporting them during that deliberation process, during the assessment, since they all performed equivalent to, two of the modes performed equivalent to T-piece, which is essentially no ventilator at all. If that answers your questions. Sorry, I kind of rambled on.
No, that does answer my question. And as I was looking at this data, I freely admit my bias. My background is predominantly pediatrics, so a T-piece was never something that we did simply because of those tiny endotracheal tubes. But even when I would flex over to the adult world, T-tubes always bother me. It was never one of my favorite modes of spontaneous breathing trials, although I get the point intellectually. So even though when we look back at the outcomes of this study and we see when we look at the ICU mortality, it's not statistically significant, but when we look and see how many people in this study, the mortality rate in this study, we do see the majority of the folks who did succumb did so in that T-tube cohort. Now, I don't know what that says about the T-tube itself or some other confounding factor within that group, but that does, even though the p-value is high enough that it doesn't lend itself to statistical significance, it does make me wonder, again, about the T-tube and the inherent dangers in that.
Yeah, when you look at the p-value, and I guess it's important to understand the p-value as well, although it's not 0.05, many articles will say the words such as, there was a trend towards something. And a lot of the time, if a p-value is less than 0.1 to 0.05, a lot of people will throw out the word trend. They didn't put that word in the in the manuscript, but when I looked at that information, and this is from Table 2, which I can also skip back here, and we'll just call that up here. So right here, you can see that it was 7.6% of the patients had had ICU mortality, and you can see the p-value is basically 0.09. So it's definitely something to look at. This study more than likely is not powered to show that from a primary standpoint. This is a secondary outcome. I probably would need to have a few more patients in the study to show that, but it's definitely an eyebrow raiser. I did definitely consider that. I wasn't sure I wanted to bring it up, but I'm glad you did, because then I feel comfortable talking about it. And if you also notice the length of time spent in the spontaneous breathing trial, it was also significantly less in those patients, which would indicate that perhaps they were struggling more than the other patients. So did this struggle have a negative effect overall? And you can see the time spent in the spontaneous breathing trial. So these patients weren't tolerating long periods of time, whereas the average pressure support was 45 minutes and the average PAV plus was 45 minutes. So yeah, I think you're right. We personally in our institution don't use the T-tube. There's been occasions where we have. We generally try to steer away from it. And there's one other thing to consider that's not really mentioned in this article, and there's probably a number of people in the chat that may have this experience, but patients who are failing extubation or failing spontaneous breathing trials, and you put them on, let's say, T-piece or let's say pressure support weaning, we tend to underestimate the ability of the glottis to maintain positive transpulmonary pressure in a patient. And when you have an obese patient, a lot of these results are not easily generalizable to this patient population. We're a bariatric center, so we get some large patients that we won't go less than a PEEP of between 10 and 15, and many patients we extubate from PEEP levels or CPAP levels of 12 to 14, and they are totally fine. They extubate successfully, no issues, and as soon as they have the control of their glottis and you've taken away the tube and any increased resistance to breathing, they generally don't have a problem. We have very few, I think we might have one obese trach patient in our ICU right now for other reasons other than respiratory failure. It's more of a neurological issue with him right now, but generally we tend to extubate our largest patients quite successfully from higher settings. So any of these therapies, so the pressure support group had their PEEPs had to be, I think for screening was 8 or less, but so they had to be on low levels of PEEP and a pressure support of 7, and we just wouldn't challenge our larger patients in this way. So this is very difficult data to generalize to all types of patients. Although they did in the study randomized, they did it nicely, but they didn't make a comment about patient BMI, etc.
So I have a quick question for the group. We have about just over 300 people in the room, so I'm going to clear out the prior responses. And so my question to the people who are hanging out with us today is just to follow up to the discussion we're having here. Do you use T-pieces, T-tubes, to do spontaneous breathing trials in your facility? Just give us a green check mark for a yes or a red X for a no. This is just a quick informal poll. And then as we're kind of going through this to see who does what, you touched a bit on generalizability and the limitations with this, and the researchers were very clear on the constructs and what kind of population they use this for and so on. So, you know, as we look at the reasons for admission and the patient's issues with their chief complaint and so on and so forth, it's not a very uniform distribution of those different types of issues. But again, this was the sample of who came in with what at any given point in time. So I guess my thought process is, should we worry too much about, for example, should I be using with my COPD patient with and airway disease, should I be worried about trying to use T-tube versus something like PAF Plus, or so should I be concerned with this about these different types of comorbidities or chief complaints or what have you, and how well can I generalize to those populations?
This is a very this question doesn't only apply to spontaneous breathing trials, but pretty much almost any modality of ventilation. I mean, we could extrapolate this conversation to even the use of PEEP, for example. So although, the types of patients admitted in the study, it wasn't very vast, the COPD and a couple of trauma with and without brain injury, so it wasn't like there was a large population, like there's no mention of pneumonia, so we don't know how well this will work with those types of patients. I think in their one institution where they mostly have a certain type of patient, it appears, these three things performed well. But I think what's important to understand is that generalizability of any randomized control trial when it comes to mechanical ventilation, I think needs to be done with caution, simply because there's going to be patients that don't tolerate something in one group and the other group, and you end up with sort of a wash. So I give the example of high versus low PEEP. In the high versus low PEEP studies, if you had patients on high levels of PEEP that didn't have recruitable lung units or didn't tolerate high levels of PEEP, they obviously wouldn't do very well. And if you had patients that required higher PEEP for whatever reason, because maybe chest wall elastance was the bigger issue than lung elastance, and they needed the higher PEEP, but they were randomized to the low PEEP group, they're also not going to do well. And the whole idea is that do we just do something because it's been in a randomized trial and it seems to be working this way, or do we really consider the physiology of the patient? So when it comes to weaning a patient with COPD with clear issues with airway resistance, lung compliance, etc., perhaps the method you choose should sort of revolve more around what type of underlying condition they have, their reason for admission, etc. Unfortunately, trying to get a large enough randomized control trial of only those types of patients and then randomizing them to 3 different methods becomes challenging. So hospitals tend to randomize their entire populations, and again, although it seems like, oh, well, we can generalize it that you can just use whatever you want with any kind of patient, it really should be done with caution. It really should be about individualizing the care of the patient. And unfortunately, individualizing the care of a patient does require a deeper understanding of the mechanics, the lung mechanics behind it, which I think respiratory therapists have the potential to excel at and really bring that knowledge to the bedside. But if they're not bringing that knowledge to the bedside, then the clinician or the intensivist, the physician in the ICU is just going to look at the data and say, well, we can do whatever we want because they're all equal.
That's a really good point. I always wonder how much I can actually apply what I've learned in any given article, of course, to that bedside. So we did our little informal survey here, and I am going to ask Reagan to help us out because I always mess it up when I try to do it. Reagan, if you would publish the results of our study here to see how many people use the T-tube in their facility and how many don't. Okay, so We had about 100 people participate in our survey. The majority who responded don't. We had a few people who also responded in the chat area who also said no, they do not use T-tube in their facility. So not something, I guess, that we see on a regular basis in the U.S., I suppose. The next question that I have is a really good question that I tell you I didn't even think about as I was reading this study. And I read this article several times to prepare for today, but this question is about the assessment and the objective values that we use to determine when someone's ready to extubate. And though these researchers have done a pretty thorough job of evaluating a lot of different characteristics, one of the characteristics that they've not mentioned is secretion production. And I think that's a little telling considering that one of the comorbidities that they've listed is COPD. So do we think that that's something that we should be taking into consideration?
Yeah, I think they had to make a choice in terms of what they were going to explicitly look at. And I know when you look at the data, I know there's another question that, and maybe you captured the question, but it's somewhat related to these sort of pre-assessment, because they did look at cuff leak, for example. They didn't state whether or not they prevented anybody's extubation because of it, or if they prevented someone from being in the study because they didn't have a positive cuff leak test. The data out there regarding cuff leak test and secretion clearance, it's more the frequency of suctioning, but I don't think, and someone can correct me if I'm wrong, but I recall looking through the data on this previously and not finding anything extremely strong in terms of preventing someone from obtaining or from performing a spontaneous breathing trial or extubating them based on secretions and or cuff leak again as well. I think there was even an article published in Respiratory Care looking at cuff leaks and whether or not they have a predictive value for failure. And I think overall, them looking at the RSBI and the maximum inspiratory pressure, which even that could be questioned, adding the cough and the cuff leaks, perhaps that was a bias on their end. I don't know, because I would think there's probably as much data telling you should look at secretions as there is, positive cuff leak or a cough, for example.
So when we're looking at, I guess my interest would be then if we look at this, the table that you've got posted here on the screen, and we see that 36 of the subjects in the study had COPD and not evenly dispersed amongst the three different groups of intervention. I wonder if, I'd love to see the data stratified to see if COPD had any kind of impact on the success of any of those types, simply from that perspective of perhaps a secretion issue or some sort of change in airway issue.
Mm. And again, I think they need more. I mean, they had 36 patients with COPD, so they probably would need even larger patients, especially in this randomized trial, whether or not one was a better feature or not, or a better technique or not. But yeah, I agree. I did not find anything that mentioned secretions at all. And I read it a few times either. I mean, perhaps I could do a search, but it definitely wasn't discussed nearly as much as some of the other things.
So when we talk about this study specifically, and they're talking about a successful extubation, just to go back to that for just a minute to clarify, are we talking about a successful extubation to bilevel positive pressure ventilation, to CPAP, to nasal cannula? What kind of intervention was deemed successful for this study?
Yeah, so what they were doing in terms of extubating COPD patients directly to non-invasive, that would have been BiPAP. I saw one of the questions was, is this CPAP or BiPAP? They're referring to BiPAP, and they're referring to a paper, I forget the author's name, it might have been Stefano Nava was involved with it, and it was post-extubation straight to non-invasive for patients with underlying hypercapnic disorder. This whole idea of need for non-invasive post-extubation. So if you look at the bottom of the screen, there's a need for non-invasive post-extubation. I think they were looking at 0, 6 to 12, like 0, 6 to 12, and 12 hours post-extubation, people that they felt needed non-invasive ventilation. Although the data for using non-invasive post-extubation as like a rescue strategy, so not direct extubation, but let's say 6 hours down the line they fail, the data for providing BiPAP in that scenario is actually negative. It's not a good idea to do that. So I'm assuming that need for non-invasive post-extubation is actually referring to failure in which they used it, not the direct extubate to BiPAP. But that's confusing because this is post-extubation, but it's difficult. They also say they analyzed 0, 6 to 12, and 12 hours post-extubation need for non-invasive. So, sorry, I sort of lost track of the question there, Sean. I apologize if I haven't answered it yet.
No, I thought that was that was perfect, especially the reminder that non-invasive as a rescue method several hours after extubation is not necessarily a good idea.
Yeah.
And then one more question just came through about the delirium characteristic and how significant that percentage was. Do you think that percentage of delirium was elevated due to the neurologic and traumatic brain injury cohorts, or the sample sizes of the sedation used within the samples?
That's a good question. They do have a lot. I mean, the traumatic brain injury patients was, of the total number of patients, was 27%, and then there's the medical neurological, another 12%. It's hard to say. That's a good chunk when you add them together. You're looking at almost 40% of the patients. So 55% of them having delirium. I'm not assuming that they're all those patients specifically, but yeah, it's definitely a high number. Now, distributed throughout the three groups, again, not significant in terms of, it looks like there's slightly more. I mean, compared to the PAV Plus, the T-tube had 61.9% versus PAV Plus of 50, but again, when we look at those numbers, we go, oh, that's a lot higher, but the p-value of that's 0.55 in terms of its distribution, so it's not probably not significantly different. I mean, it's not according to the p-value, but I'm guessing half the patients having delirium is more than likely because of the types of patients, or their method, or when they're assessing it is, there's some sedation on board at the same time that they're assessing this. This is just this was the pre-enrollment data that they were looking at. So these patients were just transitioning. They were feeling they're just ready now to start this liberation process, and the question is whether or not every patient clears sedation as easily as the other, and how that impacts extubation. The nice thing is it looks like it's relatively evenly distributed from a p-value standpoint, so it shouldn't have been that, if one group had, higher delirium than the other, you would expect them to have more extubation failures, and the extubation failures weren't significantly different between the three groups.
So as we wrap up our session, if there are any researchers on the call today that are thinking, I might want to try something like this to see, what kind of a result I could get in my facility with this kind of a study, do you have any recommendations on how you would improve upon the methodology, or maybe some things to avoid as you're developing some sort of research?
I would like to see something similar to this, where, PAV Plus now been done. I think it would be interesting to have a straight-up comparison of T-tube pressure support and then a CPAP level. Because to me, CPAP seems like the compromise, however, the level of CPAP is probably what's going to be more important, because as I mentioned earlier, if you have a patient on a low level of CPAP, even if you're giving them pressure support may actually help overcome some of the de-recruitment that's occurring in terms of it's a little bit of pressure helping them with their work of breathing, whereas just giving someone low CPAP may not be very effective. But I know that our method here, generally, we do the compromise. We don't do T-tube. We don't do pressure support, we do CPAP, but our CPAP level does depend on some underlying characteristics of the patients. For example, if they're obese, we won't give them low levels of CPAP. We'll extubate them from 12 or 14 of CPAP. For most patients, we'll get down to 5 or 6 of CPAP, and basically that's our spontaneous breathing trial, is no pressure support ventilation and just the CPAP level. So it'd be interesting to see these three methods go head to head. again, the more difficult way to interpret the data. And again, if you put someone who's overweight on a T-piece, you're probably going to not have very much success. So it would, again, come down to your patient population and whether or not it's appropriate. So again, you might end up getting another wash of results where the patients that shouldn't be on T-piece, if they get it, they're not going to do very well. The ones that shouldn't be on pressure support, they also, it may not help with the results. But I think it's going to be a difficult one to improve upon, but I think just adding other methods that people use, like CPAP. And I know there's some papers out there comparing CPAP with other methods, but I think it'd be nice to straight head-to-head comparison with these methods, but with CPAP. And then again, then you have something that's not proprietary as well. One way to improve upon the study is to make it generalizable to the point where it doesn't matter what ventilator you have, you can do it. This study, for example, it does require you to have a PB840 or 980 in order to compare these results.
Fantastic. Well, Tom, thank you so much for joining us today.
No problem. The pleasure was mine.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.